afternoon, everyone. This is Heidi Hartman. I'm the president of the Institute for Women's Policy Research. We're delighted to be with you here this morning. We have a wonderful panel whom I will introduce in a few moments. Right now, I want to tell you that the title of the webinar is Work Supports for Adult Health, the Role of Paid Family and Medical Leave. And it's sponsored by the Robert Wood Johnson Foundation, who has given IWPR and the University of California at Berkeley a 2.5-year grant to study policy supports and how well they do or don't help working families. So we couldn't be more delighted that this 3-session webinar has been one of our first efforts, and we hope the webinar will continue in the fall with other topics and other forms of work support besides family and medical leave. So for now, I am, and I should tell you also that the voice recording of the webinar is available on our website, including the 2 earlier ones, and also that there are the slides that the speakers use will also be available on our website. The website is iwpr.org. So for my overview this time, since this is an area of paid family leave we do a lot of research in, I want to present some work we've been doing at IWPR. We have a simulation model which simulates how much leave people will take, especially if it were paid, and this is based on the behavioral assumptions that come out of the last Family and Medical Leave Survey, which is conducted for the DOL, the U.S. Department of Labor. So the title of my slides is an overview of usage and benefits under 4 potential nationwide family leave insurance programs. And I did this work with Jeff Hayes, who is here, and will be able to help answer any questions you might have. So in the first chart, Table 1, I'm just showing you what the 4 family leave programs that we are modeling on a national level are. There's the Family Act, which is a proposed national one, California, which is a state level, New Jersey, another state level, Rhode Island, another state level. So they've been in, can we go back to the 3? So they have been in operation for different amounts of time, but California is, fairly old, from 2004. And the first thing that you can see is that they have different benefits. Some have a high maximum wage, some have a low earnings requirement to get in, others have higher earnings requirements, different lengths of time that they provide benefits for. So it's interesting to see how the different specifications of the different models affect how many people will take leave and basically how much money they'll get out of it. So in our first next table with a bunch of numbers, which I hope you're sitting up by your computers and you can look at, you can see that these are just the benefits under the program. This particular table doesn't count any benefits from any other source. Quite a few workers do have some benefits for family and medical leave insurance, and those are generally from their employer. Paid sick days, some have paid family leave, very few, but they may have a vacation they could use, and they may have disability insurance that comes from their employer, or even that they buy separately. So these are wage and salary employees all across the country, but the models come from these states. So as you can see, it's about 9 to 10 million people per year who would receive, who would participate in one of the insurance programs and would take the leave for the amount of weeks you can see there and for the different types of leave. So just to be clear, the biggest type of leave that people use is a serious health condition, the medical part of family and medical leave. That's the largest. Maternity, parental, that includes paternal as well. This is newborns and care of newborns. Also fairly high, but about half of the amount of sick leave or even less. And then family care is very small. It's less than 10% of the total leave takers. But it could be very important. You could help your older parents, you could help a spouse, you could help a child who's seriously ill, after their first year of life. So you can also see that the weeks of receiving the benefits are the generally higher for serious health condition or maternity and parental leave, lowest for family care. Usually when you're helping another family member, it has to be a serious illness, and you're usually making some kinds of arrangements. Perhaps your child is in the hospital, you want to visit them, but then when they come home, you have a different arrangement. The same with your older parents. You may be working on new arrangements if their care needs escalate. And you can see the average weekly benefits. They're not, they don't put you in the lap of luxury, let's put it that way. Even where the highest benefits go up to $1,000, there are a lot of low-wage workers getting these benefits, and so the average benefit is right around $500 or a little less in each of these programs. When, don't forget, these are not what's really happening in California. These are what would happen if they were programmed on the national level. And so the benefit costs are in the range of $30 to $35 billion, and the cost as a percentage of the total payroll is less than 0.5% for each model. So that just gives you an overview of what happens if we were to put any of these programs into place at the national level. The next chart shows you how much having paid leave increases the share of workers taking leave each year, in 1 year, in other words, and for these different reasons. So basically they increase from 7 to 11%. The number of paid leaves, the number of leaves taken overall increases by 7 to 11% when those leaves are paid. The Family Act and California do the most to increase leaves, but they're all, quite high. But what we're really comparing it there to is over the current situation. This is the first table that has that. The current situation is the Family Medical Leave Act, which is unpaid but gives you a very important right, which is the access to getting your job back. So what we're really saying is that 14.6 is about 9% more than 13.4%. Did I get that right,
yes.
Jeff? So it's the increase from what you do now with just FMLA at the national level to what you would do if you got a paid leave at the national level. So these are substantial. They're not breaking the bank. It's not like, I'm going to lose my whole workforce. They're all going to be out on leave. They're all going to be taking care of their ancient grandmother, claiming that she really needs help. That isn't likely. Not too likely, anyway. Some inventive people might figure out how to do that.
And these are, again, within 1 year. And so while family care might be the sort of on the less used edge of things, people are going to be needing that leave for any time in their career. It won't be sort of concentrated like the parental leaves would be. And so that's, this sort of a year over year, so everyone is likely to need one of these adult family care leaves.
That's an excellent point, Jeff. And that's relevant because, most women these days are having 1, 2, or 3 children, and dads as well. So, you could see being done with that leave relatively early in your life, whereas this leave could increase as you age, and also you could use it anytime. You could be 21 years old and needing to take care of a parent. So the next graph, figure 4, is showing us how the access to family medical leave insurance programs would work out for families of different income ranges. So on the blue bars are your family income is less than 200% of poverty. The orange bars are in the middle, 200 to 400% of poverty, and the gray bars are having income level of 400% more, times the poverty level, and I should say for your family size and composition, because in this group we probably know that varies depending on how big your family is and also who's in your family. So these are quite substantial increases in getting access to paid leave, so that even though I said a lot of people have some access to paid leave, that mostly applies now without any plans, that mostly applies to upper income people. So here we can see that increase to paid leave for low income people, less than 200% of poverty, which is often considered poor and near poor now, increases tremendously, almost by 50% under all programs. I will say that the New Jersey and Rhode Island program are a little bit less generous than California and the nationally proposed Family Act, but they're quite significant. There are also significant increases in the access to paid leave and the use of it for middle-income families, 200 to 400% of the poverty level for their family size, and even a small increase for those at the top of the income distribution. So I think what we can say about this is that this program is doing what everyone who is supporting it hopes. It's going to the disproportionately to the low-income families. So like most social insurance, it has a redistributive effect. Now we're going to look at Figure 5, which again looks at FMLA benefits. And the difference in the dollar amounts of these benefits reflect the way the programs are designed. So having a high wage replacement rate means you get more dollars, and having maximum weeks available also means you get more dollars. So again, you can see that in terms of who gets the most dollars even per week, it's not just because of the, wait a minute, this is dollars per year. Sorry, these are dollars per year. So it is both the length of the benefit and what the wage replacement rate is, as well as your own wage. But again, it's the health, your own health, medical leave, and maternity and child bonding. Those are get the highest benefits, and the family leave benefits are lower primarily because you're not using it for as much time. I mean, you're not even using it for the amount of time that's available. So I think that's something very interesting that can be used to support these programs. And I think, is that my last breath?
Yes.
Yes. So with that overview, I hope that wasn't too rushed, and I'll give you a quiz. I'm sure you have it all memorized by now. I want to introduce our first presenter, Kanika Arora. She's an assistant professor in health management and policy in the Department of Health Management and Policy at the University of Iowa. And she completed her PhD in public administration at the Maxwell School in Syracuse University. And her research is very interesting because it looks at how the long-term care services may be affected by the availability of paid family and medical leave. So I'm going to stop there because with all of our presenters we could go on for quite some time. And we do, of course, recognize Doug Wolf as well, who was the co-investigator in this work. So thank you so much, Kanika.
Hi. So thank you, Heidi, for introducing me and for having this webinar that we can all participate in and learn from and see the work that you're doing in IWPR as well. So thank you for the opportunity. So as Heidi mentioned, I would like to present this co-authored work with Doug Wolf on looking at how paid family leave in California may have influenced nursing home use. I forgot to put the citation for the paper. I'll send that separately. But this is a paper that was published in the Journal of Policy Analysis and Management in 2017. So essentially, conflicts, as we all know, between paid work and family life have been increasingly salient over the last several decades, and specifically in reference to elder care, not only because we have an advancing population with aging population with the aging of the baby boomers, but also other demographic changes, social demographic changes. Women's continued high levels of employment. We also have high divorce rates, reduced fertility, and delayed childbearing, all of which make this conflict, this tension, even more severe. So we have these demographic changes, and when it comes to elder care, which is unique, it's a little bit different than taking care of a newborn child or child care, because as individuals are living longer, there's this lengthening of life expectancy. Most elder care needs stem from unexpected crises, like a fall, for instance. So these needs are sort of difficult to anticipate or plan for when an individual, in this case an informal caregiver, typically an employed woman, is engaged also in paid work. So because of this issue, I think this conflict between paid work and elder care is is getting extremely salient over the last several decades. As we all know, workplace policies can provide support for people who might be juggling this conflict. The U.S. does not have a statutory federal policy, but as we all know, the momentum is increasing. California being the first state to mandate paid leave, and then 5 other states in D.C. have sort of followed suit. So existing research, or I should say at this point, since this paper was published in 2017, a majority of the existing research on looking at the effects of paid family leave has looked at direct effects of provision of family leave at the state level. By direct effects, I mean effects on employers and employees. So for employees, for instance, policies have looked at how the provision of PFL can increase labor market attachment among parents. As far as firms or employers are concerned, researchers have looked at how the provision of PFL actually has incurred very few costs on employers and actually has helped them gain substantial benefits in terms of employee attachment to jobs and so on. But very few papers have looked at indirect effects. So for instance, effects on health. So some people have looked at if paid leave policies or disability policies can influence low birth weight in children. Also have looked at maternal health as well as child health. But this is the first paper, our paper, looking at sort of the effect of PFL on market-provided services. So for instance, does paid family leave affect daycare use, or in this case, as we are studying it, nursing home use? So that's the question that we are trying to address. And I think this has very important policy implications, especially when you look at nursing home use. It's the largest proportion of long-term care costs in the country, majority of which are paid by Medicaid. And beyond just being financially burdensome for individuals and state and federal budgets, I think it's also, nursing home use is also widely unpopular. Individuals would like to be taken care of at home than institutions. So I think from a policy perspective, this is an important topic to consider. But also, I think, so here we use state-level data for 50 states from 1999 to 2008 from many sources. Our panel sort of ends in 2008 for two reasons. One, because we have information available on nursing home use consistently from 1999 to 2009. And then we dropped 2009 from our analysis because 2009 had only New Jersey sort of implement half a year of their paid family leave law. And since the California effects, if there is anything, would dominate anyway, we just dropped 2009 so that we have a very straightforward interpretation if there is anything going on. So in our data, the main thing that we're looking at is nursing home utilization. We look at it as a proportion of the state's older population that is resident in a nursing home at any time during a calendar year. So essentially, this is the main outcome. So the numerator here is just the count, or I should say unduplicated count of nursing home residents age 65 and older, and the denominator here is the state and year-specific counts of people 65 and older in a particular state. So for every state, for every year in 1990 to 2008, we can construct this proportion. The main thing that we're trying to look at is the effect on nursing home use or as a response to this policy. So we're looking at California. The law was passed in 2002. It went into effect in 2004. So what we have is that it's basically the main idea is the PFL sort of lights up after 2004 in California. It doesn't for other states. We dropped 2004 because, we have half a year of policy implementation. The other half doesn't. So that makes things complicated. So we dropped 2004. We also have a lot of other data regarding the features of states' long-term care environments as well. Our main methodology here is a quasi-experimental method. What we use is a difference in differences analysis. And essentially the idea here is to contrast changes in nursing home use in California before and after the enactment of this policy to any corresponding changes in nursing home utilization in a set of comparison group states. The basic idea here is that, we would like to look at changes in California before and after the law and compare it to the changes before and after in other states. So basically, the way we choose our comparison group here is important, and we do it in 3 different ways. One, we use data to tell us, which states are similar to California in terms of their trends before 2004 in nursing home use. We call that a cluster analysis. And then we use also a logical criteria, look at sort of other states that may not have passed paid family leave, but may be considered family friendly because they may have expanded their Family Medical Leave Act and some other policies as well. So that's kind of our family friendly states that might also be considered similar to California. So they might have passed paid family leave beyond the time frame that we are looking at, but you could consider them as states that might be considered similar to California. And then we also look at all other states as compared to California. Since we just have one treatment, we sort of adjust for that in the inference in our model. And so essentially our cluster analysis shows us that, we have, if you look at just, a lot of these variables that we have at the state level, a lot of Medicaid policies, con, moratoria, Medicaid reimbursement rates, nursing home utilization rates, before 2004, if you were to come up with an average for all states on all of these variables, instead of put them in groups in terms of how similar these states are, we come up with sort of 8 groups. And California is in the first group, which has 16 other states. So essentially our model was sort of telling us that these are the 16 other states which on a wide range of variables look very similar to California in the pre-2004 period, so between 1999 and 2004. So these groups are our empirically derived sort of control. And the superscript A basically says that they were also in the family-friendly comparison group. So it's just a little heartening to see that a lot of the ones that we actually found empirically also sort of ended up being in the family-friendly dimension as well, and the logical criteria. So then we just plotted, the trends in the proportion of nursing home use, among older adults in all of these groups. So as you can see here, one of the main things we see is that nursing home use is declining over time. The black solid line is California. The other lines are for other control groups that we talked about, so all other states, the other states in the California cluster, and other family-friendly states that come up with from a logical basis. So in all of these groups, we see that over time nursing home use has been, there's been a downward trend in that. So on sort of basically visual inspection, we can see that the California trend closely parallels that of the other groups, but lies well below it. And that's not a very big surprise because California has the lowest supply of nursing home beds in the country. It's also been a leader in development of alternatives to nursing home use. And it also has the largest share of non-native born individuals who tend to use nursing homes in a smaller percentage. So if we look at just, the change right after 2004, we don't really see, a big drop, right, in terms of nursing home use. But we do see that, so it suggests that if there is a change, it might be small, or, there might be offsetting effects that our graph really doesn't sort of capture here. So then, since we want to control for these offsetting effects, we wanted to sort of put all these other things in our model to see if there really is a paid family leave law effect. And so there are these 3 models that we ran, and essentially the first model is looking at the states in the cluster as a comparison group. The second model looks at the family-friendly states as a comparison group, and the third model runs with like California as a treatment and all the states in the country as the comparison group. And we control for a bunch of things as well as some other things that you would note in the footnote as well that are important to do so. And we find that consistently the paid family leave law actually led to a statistically significant decrease in elderly nursing home use. And so it's sort of the range is from like 0.05 percentage points to from 0.72 percentage points. And it's small, so it's 0.65 percentage points, which is almost like 2/3 of a point. But the reduction might appear small, but if you look at it from relative terms, because the base is small, the nursing home use in California is already small. If you look at it from that perspective, it is a big sort of reduction. And I'll talk about that in a second. So as I mentioned, our results sort of provide consistent evidence of a reduction in nursing home utilization, and our estimates range from 0.05 percentage points to about 0.72 percentage points. As I mentioned, we do a lot of robustness checks to see if this is a fluke result or are we really seeing something that's there. And you can sort of read about that in the paper. But in terms of the highlights, we try to sort of see if, we have a placebo from a placebo perspective. If we were to just say in our data that, the policy started before 2004, would we see a similar effect? And we don't. The other thing we did was, let's say we arbitrarily gave each of the other states which didn't implement a PFL law in this time period, a 1 on PFL implementation. Let's just say, okay, is it just something that's happening in the data just because we have one treatment? Is it by chance, or is this really happening? And in all of those robustness checks, we find that it only happens if you look at in California after 2004. And so if you look at what was happening in California, the average in terms of nursing home use, the percentage of people who were the proportion, and then look at, what this drop of 0.65 percentage point really means, it means a relative decline of about 11% in nursing home use in California, which is pretty big because the base that we're starting from is small. The other thing I would like to point out is that our estimate of the PFL impact, just based on the nature of its construction, can understate the true policy impact, because what we have, the way we're looking at nursing home use is the count of individuals who were there in a nursing home for one night or more in a year. But, what about people, who were in a nursing home whose complete stay wasn't averted, but, it may have been reduced because, because of the availability of paid family leave. So that's something that our model doesn't capture. So from that perspective, our impact is, our estimate is actually understating the true impact. So I want to mention that to the best of our knowledge, this is the first study that empirically examines the relationship between paid leave and long-term care outcomes, and I think this is important as the population continues to age, and we have concerns about Medicaid budget as well, especially with this discussion early on in the Trump administration about putting caps on Medicaid budgets. And this would be something that would be important to look at because it's the biggest cost item as far as amount of spending that Medicaid does is concerned. I would mention that, the study has multiple limitations, one of them being the fact that, the paid family leave implementation is not randomly assigned, but we try to address it by including a bunch of covariates as well as, multiple different kinds of control groups and robustness checks that add confidence to what we are seeing. The time period isn't long enough to capture Rhode Island and New Jersey. And finally, I think we are unable to demonstrate, because all of this is aggregate level, we are unable to demonstrate how is this really happening. We do have empirical evidence to suggest that this is probably happening because individuals are now available to take care of their family members because there's more supply of elder caregivers because of the provision of family leave, but we haven't really been able to make that link that that's why this is happening. So there is evidence that leave taking generally increases after paid family leave, and we also know from other research that informal caregiving and the use of nursing homes are actually a substitute. So we know that also happens. So from that perspective, we can understand why this is happening, but we weren't able to test this empirically in our paper. But I do think this is an encouraging result to show, especially from a policy perspective with long-term care outcomes. So that's all I have.
Well, thank you so much, Kanika. That is an amazingly large result, I think. And it certainly shows how much paid FMLA can do for elder care. And it'll be interesting to see, more research in the coming years, how many studies can show a similar effect, and will we get studies that link the results to the amount of caregiving that unpaid family members who were previously working or only working, now they can get leave and go back to work possibly, how much difference that makes. So I am next delighted to introduce Indy Duda Gupta. He is the co-executive director of the Center on Poverty and Inequality and the Economic Security and Opportunity Initiative, and he's also an adjunct professor of law at Georgetown University. He and I have had the pleasure of serving together on the National Academy of Social Insurance forthcoming report that deals with long-term care, family care, and child care, and will be released in about 2 weeks. We can hardly believe it. Indy comes to this topic with a great deal of, like all our panelists, a great deal of knowledge and interest. Thank you, Indy, for being with us today.
No, thank you, Heidi, and the team there. Delighted to be here. I'm going to focus really on the importance of paid family and medical leave for people with disabilities and their families. In particular, I'm going to base some of these comments on a report from 2016 that we co-authored with the AARP. Let me just thank my colleagues, Callie Grant, Casey Goldvale, and Sefi Khan and Funke Aderanmu, who helped with the paper or the presentation first. Some of this will build on what we've already heard, but I just want to sort of set some obvious points here if we can jump to slide 21. And that is that nearly all of us will need paid leave at some point or another, right, to care for a family member or own serious medical condition, as Heidi mentioned earlier, to welcome a new baby or new child in the family. And people with disabilities, workers with disabilities, need paid leave for the same reasons as everyone else. And people with disabilities are themselves often caregivers. So I think that's important not to sort of see them as two distinct roles that the same person can't play. What we found in the sort of synthesis of research and some original analysis here is that obviously paid family and medical leave can be particularly important for families with a disability, whatever the reason is that they need the paid leave. What I'll do is I'll just provide an overview of disability and work in the U.S. If you go to the next slide here, 22, and then I'll go through some key findings and policy recommendations. The policy recommendations are somewhat general and more principles, but I'd be happy to talk more specifically. We're also engaged in a major project with Paid Leave US, and we'll be releasing a paper later this year in the coming months on sort of pulling together a lot of research on racial and gender equity and the impacts of paid family and medical leave on health, labor market, and education outcomes, and what that might mean. So this will be high level today, but rest assured there'll be more specifics coming out soon. So disability, as many people here will know, about 1 in 5 people in the U.S. have a disability, and you can go to slide 23 and see, of course, disability incidence rates rise fairly substantially by age, especially in later years in life, and about 1 in 4, over 1 in 4 households includes at least one person with a disability, which I think is important to keep in mind. There are an estimated, by our calculations for 2017, 3.7 million children, 26.3 million working age adults, and 17.4 million seniors who experience a physical, mental, or sensory disability. If you go to the next slide, you can see the intersection of disability, unemployment, and race. So one of the important things that policymakers are obviously going to have to consider is how to ensure that policy like paid family and medical leave can hopefully at least shrink and certainly not exacerbate racial disparities. And you can see here that people with disabilities face substantially higher unemployment rates, period, across racial groups. But in particular, you see substantially higher rates of disability among communities of color, especially African American and Latino when compared to whites. All right, so on the next slide, on 25, we just show some basic depiction of the employment to population ratio by gender and disability. So women in, so a worker, as background, a worker entering the workforce today faces about a 1 in 3 chance of becoming disabled for 3 months or more during their working career. So that's something really to keep in mind when you think about, you often hear a lot of arguments from people who sort of give the impression that there's going to be a lot of people who won't ever need or access such benefits, and that's just the worker. That doesn't count other family members in the household who benefit, obviously, when there's support during a disability period. And you get here, though, some disparities, obviously, by gender, where women have a lower employment to population ratio regardless, if women with a disability have a lower employment to population ratio than men, and women without a disability similarly do, but it's a substantial difference there of over 10 percentage points. And one of the things that I think has been mentioned is when designed well, paid family leave programs can actually obviously increase labor force attachment. So on the next slide, just want to highlight a key points about how disability and financial insecurity are intertwined, because one of the answers, of course, to any period of not having earnings from work is savings. But sure enough, as a lot of us know, very few households can and have been able to save as it is, and this is particularly true for a lot of households with disabilities who may, among other things, face higher out-of-pocket medical and disability-related costs, lower incomes as it is, and as indicated earlier, worse labor market outcomes and employment. And there's some of that it relates, in fact, to caregiving responsibility too. So we have already nearly 7 in 10 working-age caregivers are employed, which means 3 in 10 are not, but also they may face serious penalties in their earnings and hours of work because of their caregiving responsibilities. The next slide just shows that the poverty rates for folks with disabilities is substantially higher than those without. This is actually 125% of the official poverty measure, but it doesn't really matter where you cut it. You get a very similar result, and none of that's surprising based on what we just discussed. And then if you go to, sorry, that was slide 27. And then if you go to slide 28, you can see that the financial hardships among people with disabilities are quite stark. Of course, this is not the case for everyone, but just to give a sense of it, that 4 and 5 figure of people with disabilities who lack any sort of rainy day fund, that's sort of meeting expenses for a few months without earnings. The 1 in 10 people with disabilities are confident that they could come up with $2,000 from an unexpected need. That means 9 in 10 are not, and that's actually, that could be potentially in some cases a car repair. And you have median earnings, also not shown here, but are about 32% less for people with disabilities than people without. On the next slide, 29, you can see here that nearly half of people at or below 200% of the official poverty line live with at least one household member with a disability. So I mentioned earlier how about 1 in 4 households have a member with a disability, but it's 45%. So it's the 44.8 figure toward the bottom of the chart, but also nearly 45% of those who are considered low income live with at least one member with disability. So the pattern is quite clear that disability is highly associated with economic hardship pretty much any way you can cut it. So that suggests that access to paid leave is maybe even more important for people with disabilities and their families than for others. Let's jump now to the overview slide so we can start talking about some of the key findings. And on slide 31, you can see them. I'll run through them one by one. There's a need for more inclusive and comprehensive policies. Paid leave helps workers, obviously, with their own disabilities, but also those of their own needs, but also those of family members. there's reason to believe it will boost economic security and opportunity. And then the final one, which I think is important, is that even where paid leave is sort of available, it's probably not meaningfully quite as available to people with disabilities and their families. So let's go to the first one. So the next slide, 32, it's just another depiction of a key point Heidi made, which is typically people take paid leave for their own illness. I think Jeff earlier pointed out that those may be shorter, that those sorts of leaves may be shorter than some of the other ones, like parental leave, of course, but they may happen more frequently. And one other thing to keep in mind, thinking about sort of some of the generational challenges, I'm sure Josie will chat about this later, but more than 1 in 10 U.S. parents of minor kids also provide unpaid care for an adult. And some of that's generational, but it could also certainly be another family member, another relative. So the key things when we think about the need for a more inclusive and comprehensive policy is that, as I mentioned, acknowledge obviously that people's own health needs and make sure that the leave sort of reflects that, the options for leave. But I think secondly, what we found, especially for people with disabilities, is an expansive definition of family. And we're seeing that a lot of people with disabilities, also people who identify as LGBTQ, will not be able to really take advantage of paid family and medical leave if the definition of family is narrow and it's not for their own illness. So I think that's a really important sort of difference. A lot of people with disabilities similarly rely on care from what we often refer to as chosen family, and people who may not sort of meet certain technical legal definitions, though some states are obviously expanding and thinking more broadly about how to ensure that people can actually take advantage of this leave. All right, so let's go to the next slide. So the number 2 finding, paid leave helps workers care for themselves and their family members, of course. This is a chart that just shows essentially almost half of the time the health conditions that workers who take leave for their own illness are responding to is a one-time health matter. So a smaller share, less than 2 in 5, are sort of more routine or ongoing care. So this is based on a survey of 2,800 or so employees. So paid leave can help people, in a sense, obviously take off time for a serious medical condition. That's probably a lot of the one-time health matters, without obviously seeing a sharp drop in income or jeopardizing one's job, or also your often employer-based health coverage, which I think is important to think about. We'll touch on it later, but the continuity of health coverage. And it can potentially increase access to preventive care, such as obviously going to medical appointments and overall health and well-being. And as a result, it helps a lot of folks essentially navigate their family's needs and maintain work hours while they're addressing their own needs as well. So if we go to slide number 3, so slide 34, there's a lot of fairly strong and sometimes just suggestive, but pretty clear pattern of evidence for the effects of paid family and medical leave. There's, I think, very little doubt that it can reduce poverty, that it can keep people in the workforce, potentially keeping people from being discriminated against, of course, including with job protections, with anti-retaliation measures as well, encourage people to essentially meet their and their families' needs in ways that allow them to continue working. It can potentially also prevent people from forcing to switch to part-time work or lower paying work. There was one study of parents who took advantage of paid family medical leave and found that a majority experience positive health effects in their own emotional health, as well as the physical and emotional health of their kids. And there's other evidence, I think mentioned earlier, on maternal mental health and even things like increased vaccination rates. So if we go to slide 35, this is where we talk about the importance of thinking hard about how policy can sort of, in some cases inadvertently, leave out people with disabilities and their families. Or also more broadly, people with low income, people who are younger, identify as LGBTQ, and people of color, and women. In many cases, people often think these programs are designed precisely to help these groups, and actually you can see it even from some of the simulations that Heidi shared earlier. They may be sometimes the least likely to benefit, and it depends a lot on interactions with obviously the policies, but with things going on in the labor market, like the nature of low-paid work and flexible schedules, and how people qualify for benefits. So as it is, we know that folks in more challenging jobs like that don't have access to private leave typically of any kind, even like sick leave or a subset of paid leave. And we know that it's possible that depending on how paid leave programs are designed, it could unfortunately continue to exclude them. Let's just jump to the policy recommendations. Next slide. 35, and then, sorry, 36. Policy recommendations, and then we'll go to 37. The top lines are that when you think about a program that would be equitable towards people with disabilities and their families, it's very important, obviously, to be accessible to all workers. That includes low-paid, part-time workers, even small business employees. So coverage needs to be expansive, which we can talk about. Which states that are doing that. That we need to have an expansive definition of a family. Otherwise, it's unfortunately meaningless in many cases once we move beyond own illness in particular as a reason for accessing leave. Then cover obviously all the major reasons why people need it. So this is sort of really about comprehensiveness. Have sufficient wage replacement and leave duration. So that wage replacement varies a lot now among the states. Some states like New Jersey now are going up over 80%. And then a lot of us, I think, here often point out that you can't live off of minimum wage in much of the country, or even the 10th percentile of wages or higher. Imagine, obviously, sometimes having greater out-of-pocket spending during a time of disability or other health need, and living off of even less money. So wage replacement will be crucial. And the duration matters too, of not just for the effects on kids that we know a lot of good research about, but also more generally for even recovering from health challenges. And then, of course, ensuring people can keep jobs and benefits without negative consequences, including things beyond just having the role, but the nature of the role changing when you return to work. And then I think something that's easily left out is the importance of education outreach that's fully accessible, in this case to people with disabilities. I think will be really important. So just quickly, if you go to the next slide, lessons from the states. This sort of reiterates some of what we said. I just want to point out that there are several states that now, for the lowest paid workers, cover at least 80% or more. So Heidi earlier showed a chart that had New Jersey before the most recent law, I think, because I think starting at some point in 2020, New Jersey's goes up significantly for the lowest paid workers to maybe around 85%. And New Jersey and Washington, D.C.'s forthcoming system. But then also I want to emphasize the importance of job protection. So a lot of people think about FMLA already providing that, but there's a rule about basically the size of the employer within a certain vicinity, how many employees they have, and several states like California, New Jersey, Washington, and the District of Columbia have actually lowered that threshold so that a larger share of workers can access paid family and medical leave. So with that, I can go to the next slide, 39. I'll just say overall, we found that people with disabilities and their families are less likely to have access to paid family and medical leave, even though they're exactly a group that's among the greatest risk of not being able to pay for the basics if they don't need to take leave. I think that's essentially the key takeaway, and that there's a lot of policy design options that can ensure that should there be a paid family medical leave regime, there's a way to make sure it's accessible. And there's some additional resources there on the next slide. And it's not on here, but there's also a terrific new resource, recent resource from earlier this year from Columbia University and the AARP that did a lot of qualitative collection of stories and experiences of people with disabilities in several states and their experience with paid family medical leave. So I'll be happy to answer questions at the end, and thanks everyone for listening.
Thank you, Indy. I'm on. Okay. Another very rich data-oriented presentation, and we really appreciate it. Now it's my pleasure to invite Lyn Kleinberg, who has an MSW degree and is at the American Association for Retired People Public Policy Institute. Oh, I think that was persons, but they don't use it anymore. It's actually just AARP. She is the Senior Strategic Policy Advisor there, and actually focuses on family caregiving and long-term care issues. So we are delighted to have her, and she is very involved in many things related to aging and long-term care, and is a sister or fellow member of the National Academy for Social Insurance. Thank you very much, Lyn.
Thank you, Heidi, and thank you for inviting me to be with you today to talk about this growing issue that touches so many of us in our lives when we are caring for our parents, our grandparents, spouses, parents, other adult relatives or close friends who need ongoing help because of a chronic illness, a disability, or a serious health condition, what is known in the field of aging as family caregiving. So the four main points of my conversation today are here on this slide. First, that serious illness and chronic disability affect the family as well as the individual, and that's because family and friends are the backbone of America's care system, providing the bulk of care for older adults and adults with disabilities in our country who need help with tasks of daily living like bathing, dressing, feeding, transportation to medical visits and whatnot. And family caregiving today is more complicated, costly, stressful, and demanding than any time in human history. And at the same time, we're experiencing a huge care gap, which I'll be talking about. And third main point is that we need to treat family caregiving with a new urgency and make it a national priority, not only in healthcare and in long-term care, but in workplaces too. And lastly, and importantly, and this is an audience that I know embraces this principle, and that is that workers should not have to choose between keeping their jobs and providing care to a seriously ill family member. And paid family leave is really a very important benefit for workers with elder care responsibilities. So the next slide. Shows some data from some reports from the AARP Public Policy Institute and our research center at AARP as well. And let me just briefly run over it. There are an estimated 40 million family caregivers of adults, providing about $470 billion in unpaid care to adult relatives or friends with limitations in daily activities, again, like bathing or dressing. More than 3 in 4 family caregivers incur out-of-pocket costs as a result of providing care, spending on average nearly 20% of their income on. And the average out-of-pocket expenses for family caregivers in 2016 was nearly $7,000 a year. That's the average. The costs can include medical care, medications, assistive devices, home modifications, hiring home care workers, or using other social services like adult daycare and whatnot. And the highest out-of-pocket expenses, not surprisingly, are for long-distance caregivers, that is, adults, relatives, or co-host friends who may not be living right in the same town as their parent or their grandparent. They spend on average nearly $12,000 out of pocket per year for caregiving. Very high costs. So the next slide shows that really families are at risk. We know that family caregiving, and I'm sure there are many of you on the webinar today who have experienced providing intensive caregiving for a parent or a grandparent or an aunt or uncle, that we know, although it is deeply meaningful, a 35-year body of research also shows that family caregiving comes at substantial cost to the caregivers themselves. There are physical health risks. We know from study after study that family caregivers report worse self-reported health than non-family caregivers. Emotional strain, mental health problems. There are higher rates of depression and anxiety and other emotional difficulties that family caregivers experience as compared to those that don't take on that role. Greater social isolation, the financial burdens, the out-of-pocket costs that we just spoke about, and workplace issues, the lost career opportunities, retirement insecurity when quitting a job to give care, things in that category. So family caregiving is really now viewed as a public health concern in our country. The next slide is one of my favorites because I think it really just captures where we are in our country, where it says, you take care of mom, but who will take care of you? While the need for caregiving is rapidly increasing because of the aging of the population and increased longevity, we know that the number of potential family caregivers is actually shrinking, and shrinking dramatically due to changing family structures, the other demographics that Kanika and Heidi mentioned earlier, smaller family size than in the past, and also because adult daughters of older people, who are the backbone of family care, and typically between the ages of 45 and 64, are more likely to be in the workforce today, juggling work and caregiving. And in just 7 years, in 2026, baby boomers first begin to turn 80 years old, and that's the age when people are most likely to need long-term care. And as you can see in this slide, what is known as the caregiver support ratio is in very steep decline. In 2010, we were at the sweet spot where there were more than 7 to 1 potential family caregivers in the most common ages of 45 to 64, to the growing number of people age 80 and over. By 2030, this shrinks to 4 to 1, and by 2050, it will be less than 3 to 1. So what does this mean? Essentially, it means that there will be greater pressures on a smaller number of individuals within families who will likely be working at a paying job for their own economic security, especially as the baby boomers move into old age. So reliance on families to provide care in the way it was delivered in the past, without adequate supports and protections like paid family leave, is simply unsustainable. Next slide we'll go to. So who are today's family caregivers of adults? Well, family caregiving cuts across gender, age, race and ethnicity, and disability, as Indy said as well. 60% are women, but 40% are men, so it's not just a women's issue, it's a family issue too. One thing you may not be as aware of is that nearly 1 in 4 family caregivers of adults are actually millennials, and about 40% represent multicultural communities. Family caregivers today provide about 24 hours of care a week, the equivalent of a part-time job. About a quarter of them have provided care for 5 or more years, so we're talking about a long-term commitment in elder care. Over 1 in 5 care for someone with dementia, those who are the most vulnerable. Nearly half provide care for someone age 75 and over, and 60% are employed today. So we'll go to the next slide. As I said, most family caregivers work at a paying job, and contrary to what some may assume, family caregiver responsibilities for older relatives or adults with disabilities, as Indy said, impact people across their working lives. So there are an estimated 24 million family caregivers who are employed, and they work nearly a full-time job. Half are older workers themselves, age 50 and over, and the rate of employment is especially high for millennial family caregivers. Almost 3 in 4 millennial family caregivers are employed, but a third of them earn low incomes of less than $30,000 a year, in part because they're just starting out in their work life, and they can't afford to take the time off for caregiving without a paycheck. Nearly 2 in 3 employed family caregivers care for someone age 65 and over, and most have made 1 or more workplace accommodations. So we'll go to the next slide, and the next few slides actually show the impact on employment and the financial reality. So this slide shows some data from the Caregiving in the U.S. 2015 survey that the National Alliance for Caregiving and AARP conducted. We're now in the field for Caregiving in the U.S. 2020, so stay tuned for spring of 2020 when we'll have our new data from this national survey. But this slide is really looking at the work impacts due to family caregiving, and the 2 bars, the red and the blue bar, separate out from intensive caregiving, whether a family member is providing more than 21 hours of care a week, which would be considered intensive caregiving, versus 20 or fewer hours a week. But really, all of this is to say that when employed caregivers lack the supports and the protections that they need to manage their dual responsibilities, some, not all, but some do have to make changes to their work life, especially if they can't afford to pay for outside help for their family member who may have self-care needs. And leaving a job to take on more caregiving responsibilities not only puts the pressure on the day-to-day finances of individuals and families, but it can also have longer-term consequences for the family caregiver's financial security, as we've been talking about. So in summary on this slide, for the 10% who gave up work entirely or who retired early, they typically left their job to have more time to care for their relative or because their job didn't allow flexible work hours. The workers who identify as the primary caregiver, or those who live with the person who needs care, and those who experience a high burden of care are among the most likely to report experiencing work impacts due to family caregiving. And the next slide also shows more of the data on summarizes the data on the substantial financial risks that some family caregivers experience. We know, of course, the economic consequences of reducing the work hours, quitting a job to provide care, or taking an unplanned early retirement can be significant. I'm not going to belabor everything that you see here on the screen, but losing health insurance and lost career opportunities are also key elements of the financial equation that really can impact families substantially if they have to cut back on their jobs. And the next slide also shows some of the summary of the research on the financial risks to families when they stop out of the workforce. So we know from research that family caregiving for a spouse or a parent is associated with reduced labor force participation and a higher probability of falling into poverty when compared with non-caregivers. Family caregivers who are age 50 and over who leave the workforce to care for a parent lose an estimated nearly $304,000 on average in income and benefits over their lifetime. The potential for falling into poverty, of course, is particularly acute for women, and women who quit their jobs to provide care may also find it challenging to return to the workplace once their caregiving responsibilities are finished. And the out-of-pocket spending can erode financial security of family caregivers, as I've already mentioned. So what are the benefits of paid family leave? Well, of course, on this webinar, we know that paid family leave can make it financially easier for workers to take time off from work to care for older family members with serious health conditions or disabilities. And the research in the early adopter states like California, New Jersey, and Rhode Island shows that paid family leave does have value for today's workers, those for whom they care, as well as employers and the economy as a whole. And the research to date has shown to lessen the strain on families who take on this role, to provide family caregivers with greater financial security, especially those who are lower income, reduce older adults' nursing home utilization. That's a shout out to Kanika and Doug Wolf's great research, and we need to have more research in that realm that really looks at potential budgetary savings to federal and state governments through reduced Medicaid spending on nursing home care. So really good work. And also paid family leave has been shown to increase employee retention and help maintain a productive workforce. And we know that the majority of employers surveyed in the states that have paid family leave programs have really not experienced negative impacts on their businesses. That said, we still need to have much more research on the impact of paid family leave on workers with elder care responsibilities, because most of the states that have enacted the programs, the evaluations of these programs really don't disaggregate the claims by type of family care, so we need to work a little bit more in that area. The next slide is really just a screenshot of a report that we did in 2018 at the AARP Public Policy Institute that really reviews all the research that I just mentioned and discusses the implications of paid family leave for working family caregivers. And then an article that I had the fortune of publishing this year in the Journal of the American Geriatric Society that was really a call out, if you will, to encourage clinicians, physicians, nurses, and social workers to increase awareness about paid family leave benefits to their patients or their patients' families in the states that may have enacted paid family leave programs. And then Heidi had asked me to just very briefly mention some other policy initiatives to support working family caregivers. And let me talk about two. I think that Josie's going to talk about Kapuna Care in Hawaii, so I won't talk about that state program. But there are two federal initiatives that we should be aware of. The first is the Raise Family Caregivers Act. Recognize, Assist, Include, Support, and Engage, or Raise Family Caregivers Act, that was signed into law in January of 2018. It authorizes the development and maintenance of a national strategy to support America's caregiving families across the lifespan. It's not just for caregivers of older adults, but it could also be parents of children with special needs, as well as anyone caring for someone with a disability. And it directs the Secretary of Health and Human Services to form a Family Caregiving Advisory Council to advise and work with the Secretary to develop this coordinated national strategy. It's really a blueprint, if you will. But importantly, among the core elements in the law that will be part of the family caregiving strategy is to look at financial security and workforce issues. So this is important for this group to be aware of this. And we expect the Administration for Community Living, which will be administering the Family Caregiving Advisory Council to announce in the next few weeks who will be on that advisory council and begin this important work. And then there's also the Credit for Caring Act that was just introduced on May 14th by Senators Erst, Bennett, Capito, and Warren, and on the House side, Representatives Sanchez and Reed. And it would create up to a $3,000 non-refundable tax credit for eligible working family caregivers that would help with expenses like home care, home modifications, respite care, adult daycare, transportation, travel costs, assisted living, kind of those bigger ticket items that really would help provide some financial relief for working family caregivers. Importantly, a family caregiver would not have to live with the person they care for, and the person would not have to be a dependent. So I just wanted to share some of that with you. And then just a few takeaways as I wrap up. More family caregivers of older adults will be in the labor force in the future, especially older women who are the main family caregivers in our country. Maintaining a job while providing elder care is a balancing act, financial hardship, an emotional roller coaster, and a health risk too for many. And supportive workplace benefits like paid family leave that help workers remain in the workforce and continue to provide care are really win-wins all around. And as I noted earlier, we do need more research on the impact of paid family leave and paid sick days and other financial strategies on workers with elder care responsibilities. And then again, to reinforce the principle that workers should not have to choose between keeping their jobs and providing care to a seriously ill family member. So I'll stop there and thank you.
Thank you, Lynn. That was another excellent and chock-full presentation, and I love that next to last recommendation. We need more research. I see that that's a theme in all of these, so thank you all. I'm delighted to now ask Josephine Calapenny to speak to us. She's the Director of Policy and Federal Affairs at Caring Across Generations, a wonderful coalition of more than 100 partner organizations who are all working to transform the way we care, with benefits both for the caregivers and those receiving care. We also work with her, still work with her at the National Academy of Social Insurance, where we are finishing up a report on
Universal family care.
Universal family care. I was struggling with the first word. Universal family care, which, as I mentioned earlier, will cover long-term care, child care, and paid family leave. So it's delightful, Josie, to have you on this webinar. Thank you so much.
Thank you, Heidi, and thank you for having me on this presentation. It's great to sort of follow up from Indy and Tamika and Lynn, because I get to skip a few parts and really focus on some of the meat of my presentation. I get to talk a little bit about why paid family and medical leave matters to the caring majority. And at Caring Across Generations, we're really looking to change the way we care from the perspective of what we call the caring majority, which we define as family caregivers, care consumers, that includes people with disabilities and aging adults who need care, as well as the workforce. And we're really looking at the intersection of solutions across those constituent groups, because we know that the backbone of our care system right now is family caregivers. So we have to solve for family caregivers. But we also have to solve for all of the workforce issues that are happening in order to continue to increase access to long-term services and supports and to other care needs across the care spectrum. Our work at Caring Across really centers on 3 key areas of work. We do work around culture change, which really is focusing on how to reshift our culture's posture around some of these issues around aging, around care, around caregiving, particularly to value this invaluable work in ways that then really change the social infrastructure in our country to increase support and to win the solutions that we really want to win. Of course, then there's the policy and research that we do, where both like refining and developing new and expanding existing policy models at the state and federal level, and really thinking about what a new care infrastructure could look like, as well as continued research. We do, as Heidi has mentioned a few times, that we're working with the National Academy for Social Insurance, who will be releasing a commissioned report at the end of June around universal family care, which is looking at how to pool the risk of child care, long-term services and supports, long-term care, and paid leave into one social insurance fund, and how that could be made possible. And then we also do a lot of organizing work. We do organizing in the digital world, which we find where caregivers are really engaging because their time is so stretched. And then we do a lot of state and federal organizing and base building and grassroots advocacy work. And our current policy agenda is really focused on a comprehensive long-term services and support, looking at state and federal models to increase access to long-term services and support. We're also looking for direct care workforce solutions, as well as supports for family caregivers like child care, paid leave, and financial supports for caregiving, which is where we really enter the paid family and medical leave conversation. And in our world, we really see that the ideal would be universal family care, which conceptually would pay for all of the things that families need across the care spectrum. There's a world of organizing and policy work that fit under the agenda that is happening in other spaces by wonderful organizations, and where we lean in is in really thinking about these supports from a care consumer perspective, the family caregiving perspective, and the workforce perspective. You know, the ways that our families live and work have changed dramatically over the past few decades, and yet our family and caregiving policies are still progressive much more slower than how families are really experiencing current systems. And due to the lack of paid family and medical leave, most employees can't afford to take time off when a new child joins their family, or to take care of their own serious conditions or disability, or to take care of a parent and loved one, which you've heard from multiple speakers already, that that's an ever-increasing need as we ourselves get older, but also as our parents and loved ones get older and need additional support. The need for leave to care for an adult is becoming an increasingly pressing workforce issue, and I wanted to spend a little bit of time talking about that. And so when we think about the caring majority and paid family and medical leave, it shows up in a lot of different ways. I don't want to reiterate what's been talked about already, so I want to sort of focus on a couple of areas that haven't been touched on yet. When we think about paid family and medical leave, we're often thinking about the need to provide care support to others. But when we're thinking about the fact that people are living longer, it also often is meaning that people are working longer. So young boomers are working much later than the typical retirement age. That means that there's a population of older adults that are going to be needing paid family and medical leave, because we know the older you get, the more likely you are to need care for yourself. And so if people are living longer and working longer, and as the older you live, the more likely you are to need care and to need leave, instituting paid family and medical leave at the federal level and in various states not only impacts the ability for a family caregiver to provide care, but it also supports older adults to work longer in life by having those supports in place. So I think there's also a need to understand that aging adults, as we're all living longer, we're also working longer often, will need paid family and medical leave later on in our stages of life. And I think that's a critical aspect that needs to be part of the paid family and medical leave conversation. Lyn so beautifully talked about the needs of family caregivers, and Indy started to mention a little bit about the fact that 1 in 10 U.S. parents are also providing unpaid care for an adult. And we refer to people who are often carrying across generations, no pun intended, as sandwich generation caregivers, often as people who are caring for an aging adult but also caring for a child 18 and under. So if you think about sandwich generation caregivers, not only are they already pulled across the care spectrum, but they also need to remain engaged in the labor force for the sake of their own current economic security for their families. But as we think about their own retirement security, the need to stay engaged in the labor force becomes ever more increasing for this particular population who's already stretched in the current cost of living, unable to save because of stagnant wages, and becomes even more complicated as they're needing to take time off when they're carrying across these various generations and carrying across various age spectrums. And so the needs of sandwich generation caregivers to stay engaged in the labor workforce can really be facilitated by paid family and medical leave, especially an expansive paid family and medical leave policy that allows for care for not just a child, but also for an aging adult. This is a critical population that we need to think about as we're thinking about and designing paid family and medical leave policies. I also really wanted to spend some time talking about the direct care workforce. As it is, we're living longer and therefore needing more care. And as has been already mentioned, most people desire to receive care in their own homes. And Kanika sort of beautifully set me up by saying that, nursing home use is declining over time where paid family and medical leave exists. However, that actually means that not just family caregivers need support, but people then are likely receiving care and supports in their homes. And if we don't support the direct care workforce and really think about recruitment and retention strategies for the direct care workforce, we're going to continue to see shortages where there's a care demand. We're going to continue to see increasing shortages in the care workforce. And a paid family and medical leave benefit becomes a recruitment and retention strategy that supports the direct care workforce. Not only are they themselves caring as part of their work and career, but they're also likely being pulled to care for their own children and their own families and an aging adult in their lives. And so this paid family and medical leave in regards to the direct care workforce becomes really important in how we think about the key structures of paid family and medical leave. One of the key components that I think is incredibly important to think about when we're thinking about the intersection of the direct care workforce and paid family and medical leave is the need for really strong job protections and wage replacement within paid family and medical leave structures and policies. Low-wage workers, in order to really utilize paid family and medical leave in the way that it should be utilized, the wage replacement has to be at a high enough rate that it becomes stabilizing enough to actually take the leave that they need for themselves or to care for a loved one. Additionally, those job protections become an ever-increasing issue that the direct care workforce also needs. I wanted to touch a little bit on the federal landscape and sort of how we look at all of these things combining. As I shared, we often look at the needs of family caregivers and are increasingly concerned about the needs for family caregivers. So, there's legislation at the federal level and at the state level really looking at supports for child care and supports for long-term services and support. And to really meet the care spectrum, we see paid family and medical leave as a critical component of that work. I also just wanted to share some of the ways that we really show up to this conversation. We're really bringing the voices and the stories and the experiences of often working family caregivers and family caregivers whose work has been impacted because of care and because of the lack of paid family and medical leave. And additionally, one of the stories that we continue to elevate as we want to show the broad need for paid family and medical leave is really the need for caregivers to care for an adult. There's multiple paid family and medical leave proposals out in the world, and some that only look to address the need for paid leave on the child care side. And we strongly believe that that is not sufficient, especially when we're talking about an aging population that needs to support the family caregivers who need to be able to take the time off that they need in order to provide supplemental care for an aging or disabled loved one. And so we're really stepping into this space to offer additional voices and experiences that really focus on the need of paid family and medical leave from the family caregiving and elder care perspective. In the field organizing space, we're looking to do a couple of state models that we have pushed, and I've shared some examples here. Some information can be found on our website. But I did want to spend just a minute talking about the Kapuna Caregivers program from Hawaii. In Hawaii, we passed the Kapuna Caregivers program as one way to support family caregivers. The Kapuna Caregiver program offers a benefit of up to $70 a day for up to 365 days. The target of this benefit is for family caregivers who are providing care for an adult family member and working 30 hours a week. And this benefit is to really demonstrate the needs that family caregivers have in both the caregiving spectrum, but also in needing to stay engaged and participating in the workplace. And we're seeing more and more models like that and interest in the field around models like that. And I think paid family and medical leave becomes an important structure in really thinking about the supports for family caregivers. So I wanted to sort of share a few things to remember as I sort of rush through my presentation. We always think that we need to think of solutions for not just consumers, but also for family caregivers in the workforce. And paid family and medical leave becomes one of those key critical solutions that sort of works across our constituent base. The problems are opportunities that have solutions. Again, I think the world of research around paid family and medical leave becomes really important in how we think about establishing and expanding a new social safety net for families so that they can provide the care that they're already doing but in a more supported way. And we continue to see that states are the front lines. They're incredible models as it is around paid family and medical leave moving across cities and counties and states that offer incredible data and incredible insights and opportunities to build for and expand upon it. I will pause there. Sorry to rush through that, or not sorry maybe.
Well, Josie, thank you so much. A very, very interesting presentation also. So all four of our presenters, again, I want to thank you. I do know that our software will not throw us off at 4:30, so if anyone can stay to get a few questions, we'll take them. You can respond through your computer, and we will try to get them answered at least for 5 minutes or so. And again, you'll find all the information on our website to help you get in touch with the speakers, to read their slides so you can see exactly what they said, and of course to listen to their presentations. I believe it takes a few days to get up there, Nick, and soon, so that we'll have 3 up there, this being the 3rd one. So, and thank all of our listeners for participating as well. If you have any questions, now is your chance to ask questions of 4 great experts.
I just want to also point out that in case you haven't seen it, the GAO today released a report on retirement security and caregiving that it should, again, gets at many of the topics, the ideas that were touched on here is how it's a risk to economic and financial security for families to not have programs in place.
Thank you, Jeff. I see a great question from Vicki Shabo. I wonder whether there are ways to quantify Medicaid or Medicare cost savings from the California nursing home use decline, or whether there are other dollar figures that could be calculated from the 11% reduction in use. Would you like to give us a response to that, Kanika?
Sure, I can try. I think the main answer to that question is that that's very difficult to calculate at this point using our the existing data that we have. And I can sort of speak to a little bit about why those things would be difficult. And I think I tried to answer that to you, Vicky, in a paragraph that I tried to put together. But I think one of the main things is this is a 6-week benefit. So the first thing that we might want to think about it is this affecting Medicare? Is this affecting Medicaid nursing home use? Medicare nursing home use is usually a short stay post-acute care following some sort of a hospital discharge, preceding the return to community, or home. And Medicaid is a little different. They fund nursing home use for sort of custodial care, long stay care for chronic conditions, and often end-of-life care as well. So one might think that this might be people are taking paid family leave to 6 weeks benefit. So this might be going to Medicare, which are usually short stay. So that is what it might look like. That California's law could have possibly eliminated those kinds of episodes. But that's not really clear right now, not with our data, and even in theory, because patients who are discharged from a hospital or a nursing home, usually the kind of conditions they have are very medically complex and require intensive care. So the ability of family members to actually serve as an alternative source of care for those kinds of conditions, that's difficult. That's something that you actually need to take care of in a nursing home. Long stay chronic patients, on the other hand, might require sort of custodial care and only monitoring and supervision for the most part, which can be provided at home. But so maybe what is happening is that the paid family leave benefit is shortening the length of those stays. So it's those stays might be starting much later than they would have now. So that's basically what it might be doing, or it might be affecting end-of-life nursing home stays that are also considerably shorter, So that could be one thing that it's doing. So I think without knowing exactly what kind of spells are being affected, are things, is the duration being shortened, or are we completely averting spells that would have happened and now are not happening? And what kind are they? Is it affecting Medicare or Medicaid? It's difficult to sort of come up with a dollar amount with the kind of data that we have, and that kind of data actually doesn't exist at the moment. So we do in the paper try to talk a little bit about, what does this 11% really mean in terms of, how many people how many potential averted spells there might be, if you want to look at the range of our estimates. But these are very rough and preliminary calculations because of the data limitation. So, you might want to look at that in the paper, but we don't have a monetary impact or a financial measure right now because of these reasons.
Thank you very much, Kanika. Vicki, I would like to let you know that Jeff and I hope to come up with an approximate answer. Part of the work with the Robert Wood Johnson Foundation grant is to try to come up with an answer of that, and also to look at some of the other states besides California. So stay tuned, but given what Kanika just said, check back with us in 10 years.
And Kanika, expect a call.
Yes, Kanika, expect a call, that's right. I've seen Doug too, and you're both expecting calls now. We have a question for Lyn. Can you tell us a bit more about work with healthcare sector, people in the healthcare sector, to help them integrate paid family leave education into patient care? And will your slides be available? The last question I can answer, all the slides will be available. Lyn, what can you tell? Is the health sector happy to tell patients about paid family leave?
I think the health sector hasn't really thought about that they have a role to play in increasing awareness about the ability of an individual to be able to take paid family leave in certain states if their parent or their grandparent or another relative needs additional help. And that's why we wanted to publish this article to talk about the role that clinicians can play to help increase awareness, particularly if the family caregiver goes on a doctor's visit, for example, with their older family member, and there are greater care needs and maybe fewer resources for the families to be able to purchase care. And given the shortage of direct care workers that Josie talked about, there's all kinds of issues that come up, but it may be that for a period of time, the family member might be able to take paid family leave. That could be a win-win for the person who needs care as well as the family. And the doctor or the nurse or the social worker can be that vehicle to increase awareness about these benefits, because a lot of people still don't know that if you're caring for someone with elder care needs that you might be able to take paid family leave.
Thank you very much, Lynn. I think there is a lack of knowledge about it. Is someone else chiming in?
Yeah, Heidi, this is Josie. I was just going to add that I'm really curious to see, as we dig deeper into this nursing home usage decline, what it's showing about the role of family caregivers as they're able to take leave in states, and what that does to the care planning and discharge planning and transition planning that often has to be in place for someone to transition from a nursing home back into their homes and communities. And again, sort of like a key indicator and role that the health sector can play in being able to transition someone from a nursing home back into their homes and communities.
Email.
I don't know if is that a question for me? I wasn't sure exactly, or if that was a comment.
We're waiting for Allison Earle's question. She said she had one, but thank you very much, Josie, for mentioning all those complicated reasons why making the switch from nursing home back to home or hospital back to home is challenging. Thank you. Allison may have dropped off, although she's still listed there. But I think it's a good time to end our webinar. We've kept you all, and I thank you for your loyalty at staying these extra minutes. So we've kept you all for extra time. And again, I just want to thank our presenters, thank all of you for joining. I think we're all hoping to get a lot of solutions to these problems, and with a note from Vicki Szabo that she hopes it'll not take 10 years. We hope so, too. One comment I could just make about that is I do remember being in the White House for the signing of the Family Medical Leave Act of 1993, where we really, really thought that unpaid family and medical leave was just the first step. And it would be just 5 years or so until we got paid family leave at the national level, and also until we could reduce that workplace size, down to 1 or 2 or 3 or at least 5 or 10, 15, like all the equal opportunity laws, something reasonable instead of 50. But there's a lot of happening all around in the states and the nation, and we're going to hope for change within 10 years. So again, thank you all so much.
Have a good weekend.
Yes, great weekend. Thank you.
Thank you.
Stop the recording first.